Going to give you a quick whistle-stop tour of paediatric PFJ instability, what treatments you should consider, and how you make the decisions in children. Talk a bit about the risk factors for failure, and in particular, how open growth plates affect your management, and some ideas of really of the soft tissue reconstructions we can do. So remember, with kids, redislocation after a first-time episode is high. It's from 30% to 70% in the literature, and the figure's probably about at least half of them. And although at the moment we tend to manage first-time dislocation in kids non-operatively unless they have a chondral defect that needs treating, we will find with risk stratification that may actually change with prospective studies and better evidence. But remember, if you have recurrent instability which you manage non-operatively, you risk cartilage damage. And the one thing that we know from natural history studies of children is with a first-time dislocation, the highest likelihood of osteoarthritis later in life is if they have a loose chondral fragment on MRI and X-ray at the time of the dislocation. And if you leave kids, they do get less instability when they become adults. But is that because their knees get better, or do they just learn to live with the problem and alter how they live their lives to prevent instability? But what I don't want you to think is that MPFL reconstruction in children and adolescents is not a good operation. It is a good operation. Redislocation rates are low, but most studies that are published in kids have follow-up up to 1 or 2 years. And I think you only pick up a bad operation at 2 years, you pick up a good operation at 5 years. And bear that in mind. And remember, systematic reviews are great, but they're only as good as the data that you have in them. And what we are finding now is 5-year data from kids' MPFL reconstruction that show redislocation rates that are up to 1 in 4. So it's really high. And the complication rates, excluding dislocation, are also there, even in short term. And in kids, we see a spectrum of instability. The true traumatic dislocation that happens without anatomical risk factors is actually extremely rare. We more often see anatomical risk factors that evolve into a spectrum up to fixed dislocations. And MPFL reconstruction is not going to work for the vast majority of these cases. But what are these risk factors we talk about? There's a little bit of controversy here, because when we look at studies and outcomes, we don't have a standardized way that we quantify these risk factors. But what we do know is the younger you are, the more likely you are to fail with either first-time dislocation and recurrent instability or after MPFL reconstruction. And as well as age, it's the presence of patellar ulcer and trochlear dysplasia that are the main risk factors. There are other factors: high BMI, the presence of valgus, the presence of torsion. This TTTG figure, which is a composite figure, is not one thing. You must bear that in mind when you're looking at that. And again, remember, early follow-up, bad problem. But for me, it's all about the trochlear in kids. Now, the one thing is that we understand very little about how the trochlear develops, but it continues to change up till at least the age of 11. The depth probably doesn't change much when you get to 8 and older. And after that, there's proportional growth. But what I've found as I've got a bit longer in the tooth is a bad trochlear at 8 or 11 years of age is going to look awful when they're skeletally mature. And we don't have a weapon yet to change trochlear morphology, and there isn't really good evidence that relocating a patella that doesn't sit right will actually make much of a difference. So when you're considering your MPFL reconstruction, what about the physis? Sits very close to where you're going to fix into the femur. Now, if you look at the studies that look about the proximity of the physis to where your isometric point will be for MPFL reconstruction, the studies are a little bit all over the place. However, look at the data. On the right-hand side, 3 of the studies have come from the same group. Now, how can the same group give you different figures at different time points when they're looking at where the MPFL sits? My gut feeling is it's nearly always distal to the physis. That's the safest place to put it. And in particular, the younger you are, the further away from the physis this isometric point is, so-called Shuttle's point, if you believe that that's the right place to put it. It's actually the adolescents where it's closer. The other thing with kids is we have a weapon in that we can deal with their alignment in the coronal plane with guided growth. Here you can see a case, bilateral patellofemoral instability, guided growth, restore the alignment. What we find with this is that it does reduce instability rates. It doesn't cure them, but it makes them better. There are studies, because many paediatric orthopedic surgeons can do guided growth, but can't do soft tissue reconstruction for instability. Those patients, reduction in episodes of instability. And the valgus is bad because it increases the lateral displacement of the patella, and relatively during certain aspects of the gait cycle, it will actually relatively raise your patella height dynamically. Now remember, in kids, if they've got valgus and they're about 10 or 11 years of age, it won't get better, it will get worse if anything. So we know that valgus alignment changes with growth, but once you get to that age of about 8 or 9, it's probably going to get worse as opposed to better. And you don't have to fix with hemiepiphyseodesis plates. This is an example of using the Metazure technique, which is a screw fixation. So you don't have anything fixed on the medial side to interfere with your MPFL reconstruction. There's some good comparative studies suggesting correction with this technique is actually a little bit quicker than with O-plates. But remember, with guided growth, you're playing with something that's not normal or in terms of shape. The physis of the distal femur undulates. If your plate's put in the wrong place, as it was in this case, if you look at the red circled CT, you're going to affect trochlear morphology, and that actually led to a bigger problem than just correction of the valgus. And don't forget, in the skeletally mature, the techniques are very similar to what you would do in adults. I suppose we're a bit more easy at correcting valgus in the femur with a lateral opening wedge because they fill in quickly, but you can do it on the other side and close it down if you need to. And don't forget, with deformity, assess it carefully. It's not good enough to draw a line from the centre of the hip to the centre of the ankle. Valgus can occur in any sort of aspect of the limbs. And in this case, for example, patella alta, we can see that there's a diaphyseal deformity of the tibia. So to correct that, you need to do it in a different way. Here you can see combined with a fulcus and an MPFL reconstruction. So what about rotation? There's a lot of talk about rotation now. It gets more confusing in kids, and it's already confusing in adults. So again, torsional problems do not correct significantly once you get to about 8 or 9 years of age. But in kids, we don't know what normal is. We don't know where we should correct, we don't know how we should correct, and we don't know what's more important, the femur or the tibia. What we do know is there's a lot less data on tibial external torsion than there is on femoral anteversion. But what we do know is that there does seem to be an influence on patellofemoral stability. So here's an example of an MPFL performed with a distal tibial derotation osteotomy. Now, is that the right place to do it? Difficult to know. But often what you're going to find with your patients is they have multiple risk factors, such as this. The TTTG is raised, the child has valgus, the growth plates are open, there is trochlear dysplasia, there is patella alta. I think what we could probably agree that is just doing an MPFL reconstruction here is going to give you a higher rate of failure. But you can correct all of these problems. As we've talked previously, you can perform simultaneous guided growth, MPFL reconstruction, here with a quads MPFL, and a Grammont procedure to distalize the patella tendon. But also remember that torsion is becoming even more complicated as we understand it better. We've got more talk about problems with rotation of the quads. We've got issues with acetabular version, which we don't even consider when we do a CT scan. And often it will be adaptive. Here we can see a child with Down syndrome with a fixed dislocation. There is a torsional problem, but it's occurring at the tibiofemoral joint. And this is something now we're increasingly understanding and is part of that TTG figure, which won't help if you move the tuberosity. Remember that. So what do I do for torsion with patellofemoral instability? Well, what I'll say is you've got to carefully assess everything, including for coronal deformities. It's not common in my practice to derotate the femur, partly because the evidence would suggest it's not that big a contributing factor, and we can argue that. But where you will need to do it is where you derotate the tibia for miserable malalignment and the patient doesn't have any compensatory rotation of the hip, because then they'll in-toe, and they really don't like that. But all of the data that we're using comes from the adult sector, and there are very few studies. Most of the femoral data that we get about femoral derotation comes from Germany and from one province in China. But where people have tried to look at the data, what they're finding is if you combine derotation with MPFL reconstruction, it makes slight differences, but not to clinical outcomes other than functional scores when you look at a Kujala, which is the bottom of the odds ratios you can see, and the other is to the resolution of the J sign. But that for me is not a big difference and doesn't really justify a massive procedure. We've got a lot of work to do in that area. But where we often get it wrong is with the rehabilitation. Have you ever wondered when you send your patients to physio what they're doing, how they're doing it, and if they're doing it specifically for a child who is going to be more interested in Instagram than they are in actually doing their exercises? So find out what you're doing. It takes longer. It needs better engagement for them to do well. And also, remember, you've got to keep an eye on these kids into the long term. So in summary, It's actually more controversial in kids than it is in adults, and I can't really help you much. Remember, the anatomical risk factors often coexist, so you've got to carefully assess each of them when you work out what your plan is. But no one's going to be able to give you a proper evidence-based formula of how to treat them. And ongoing growth, remember, growth can be your friend as well as your enemy. It does make things more difficult because it's constantly changing, as Caroline told you, but it can help you deal with some of the problems, and hopefully in the future we'll be able to do more for the trochlea. Don't ignore the kids. Number one rule, don't send them away and bring them back when their growth plates have closed. If you can't treat them, there will be someone near you that can treat them for you. Thank you very much.